Okay, students, we are going to look at Pons today. The earlier we have looked at midbrain. We'll see the Pons, applied neuroanatomy and physiology of Pons. Later on, we will see medulla, and then we will see the syndromes also. Why we are learning all these things? Clinically, we wanted to apply this anatomy to the clinical medicine and also to the various syndromes. So the overview of Pons and gross functional anatomy. Pons is the middle segment of the brain stem. There are three there: midbrain, pons, and medulla. This is the middle part of the brain stem, laying between the midbrain above and the medulla below. Whereas the midbrain was above is the thalamus and below is the pons. Here it is the midbrain is above and then the medulla is in the lower part. In between is the pons. It forms the bridge between the cerebral hemispheres and the cerebellum. What is the word pons known? What does it mean? Any idea? Pons. Why is it called pons? Pons in Latin means bridge. It means bridge. It is a bridge between the cerebellum and the cerebrum and the spinal cord below. Three things are there: the cerebrum above, the cerebellum on the back, and below is the medulla and the spinal cord, above continuing into the midbrain, and this is the bridge where it is bridging all those things. That's why it's called pons. Okay, so it is a key relay station for the descending as well as the ascending sensory pathways. Descending pathways are the motor pathways from the cerebral cortex, and the ascending pathways are from the periphery to the cerebral cortex to the sensory. And also the cerebellar circuits. There are several cerebellar circuits from cerebrum via the midbrain and pons to cerebellum, and then medulla to cerebellum. So many connections are there. And this is the relay station for all those things. Not only that, very important cranial nerves are also housed here. What are the cranial nerves in the pons?
5, 6, 7.
5, 6, 7, 8. 9, 10, 11, 12 are below. 3, 4 are above. 1 and 2, they don't have anything in the brainstem. 1 and 2 are exclusive direct pathways to their respective things. Optic chiasma directly from the retina. Whereas 2 and 3, the trochlear nerve is at the level of the inferior colliculus in the midbrain, whereas the oculomotor nerve is in the superior colliculus level. There is also another nucleus in the midbrain. Last time we have mentioned Edinger-Westphal nucleus. That Edinger-Westphal nucleus is the parasympathetic component which supplies the eye. So eye has got the sympathetic drive and the parasympathetic drive. The parasympathetic component of the eye, particularly the pupil, is supplied by the Edinger-Westphal nucleus. Okay, that's about midbrain. Coming to pons, just as there we have also two parts, the ventral part and the dorsal part. The ventral part is called the basis pontis. The dorsal part is called the tegmentum. So ventral is basis pontis and dorsal is the tegmentum. There we had tegmentum, and the peduncles. Three parts were there. Here we have basis pontis and tegmentum. Okay, this anatomical division corresponds closely to the functional organization of the pons. So remember, there are, as we said, two parts. The basis part, what are the main structures in the basis part? In the basis part, suppose there is an injury or an infarction of the basis part of the pontis, which are the tracts affected? The motor tracts. All the motor tracts are in the basis. That is, the descending tracts are there. Some pontine nuclei are also there. Some cerebellar connections are also there. Whereas in the top part, the sensory tracts are there. Okay, sensory tracts and cranial nerve nuclei are there in the dorsal part. That we will see. Look at the diagram here. So this the left diagram is from Gray's anatomy. So that shows there the pineal gland, which we have seen last time, and then the superior colliculus, which is about the optic connections, and the inferior colliculus about the auditory connections, and these are the superior and inferior brachii of the superior cerebellar peduncle, all that is midbrain. Below that, this area is the pons. This pons is between the midbrain and the medulla oblongata. Medulla is here, and this is the pons there. This is the side view. When you look at the ventral view or the basilar part view, there is a groove there that is called the basilar groove. And that groove is divided as though into two halves, left and right by the groove. In that groove lies the basilar artery. That's why it's also called the basilar groove. And there is a trigeminal nerve emerging out on the lateral side. And this is the abducens nerve or the sixth nerve, very medial. Any lesion here in the medial part will affect the abducens. Lateral lesions will affect the trigeminal nerve. And we have got the facial nerve, and next is the vestibulocochlear, very close by facial and the vestibulocochlear nucleus, 7 and 8. So 5 here, 6 here, 7 and 8 here. These are the main nuclei. And this is the connection to the cerebellum, the medial and the inferior cerebellar peduncles. So this is the gross anatomy of the pons. Now let's go to the ventral part. So the ventral part, also called the basilar part. Why it is called basilar part? It is opposing to the basal bone there, the bone there, and this is the basal part, basilar part, base of the skull. It is opposing to the base of the skull. It's called the basilar part. So the ventral part or basilar part of the pons is dominated by the descending cortical fibers from the cerebrum, and these can be to the cranial nerve nucleus, corticobulbar, to the spinal cord, they are called the corticospinal. It appears as a bulge on the ventral surface of the brainstem. Why is this bulge? The bulge is because of the bulk of that corticospinal tract. The corticospinal tract produces the bulge there. What is the main important tract? Corticospinal tract. Any infarction of the basal part of the pons will injure the corticospinal tract and produce motor paresis below, descending motor fibers to the spinal cord. Then corticobulbar are there, that is motor control of the cranial nerve nuclei, and then the corticopontine. If you remember, in the medulla we had the peduncles. The peduncles have got 4 motor tracts. The frontopontine is the medial, corticospinal, corticobulbar, and temporopontine. Here temporopontine fibers terminate in the pons, and that tract is not seen here. Okay, so corticospinal tract, corticobulbar fibers, and corticopontine fibers, and of course there are several pontine nuclei which are not the cranial nerve nuclei but other nuclei which are relay stations which give rise to transverse pontocerebellar fibers. These nuclei, they originate in the pons and terminate in the cerebellum. And the cerebrum gives the connection to the pons, first order. Second order are projected from the pons to the cerebellum. These are called the pontocerebellar fibers. And then you also have got in the ventral part itself, the pontocerebellar decussation, crossing, the transverse fibers of the pontocerebellar tract. Why it is important? Because one part of the cerebral cortex has got information to both the cerebellum. That is why some fibers cross. So left motor cortex is connected to the right cerebellum as well as the left cerebellum through this cross tract. Now, summarize, Vinay, what are the things here? The ventral part of the pons, corticospinal tract. And corticobulbar. Corticobulbar means from cortex to the cranial nerve nuclei. That is cerebellar connections. No. And then the pontine nuclei which act as the relay stations. And the crossing fibers of the cerebellar. Where are they? They are all in the ventral part. And this is also called the basilar part. Okay. Clinically, lesions in the pons, ventral lesions in the pons typically produce predominantly motor syndromes. So ventral pontine syndromes are predominantly motor because we have all the motor tracts in the ventral part due to involvement of the corticospinal and corticobulbar tract. And also because of the involvement of the cerebellum, we have the ataxia also will be there, cerebellar type of ataxia. If a patient has got ataxia with hemiparesis, most likely you can think of a ventral pontine lesion. So ataxia because of cerebellar tract connections and motor tract connections because of that the motor weakness will come. So you can see that there. I'm going to identify each one of them for you. You can see start the upper part is the midbrain there. So that's the midbrain, and below the green part is the pons there, and this is the cerebellum, and below is the medulla, and this part of the cerebellum here. You see the recess there. This is called the cerebellopontine angle. Several times you get tumors of the CP angle. You will be reading syndromes of the CP angle. That is the angle between the cerebellum is posterior, the pons is anterior. The angulation between them is called the cerebellopontine angle. Okay. What are the main nuclei? You see, this is we can identify the nuclei in the next diagram. Same diagram is enlarged and shown below. Go to the right side diagram. You can see the pons is couched between the midbrain and the superior colliculi and the inferior colliculi, and the medulla there and the cranial synergic. And this is the optic chiasma. This is the look from the ventral part. And this is the cerebral cortex. This is the cerebellum here. This is the projection as though you are sitting below the pons and looking up to the pons. Okay. Now, let us see that. So, first of all, the midbrain there, and there is a red nucleus there, which is related to the coordination, and you have got the mesencephalic nucleus of the trigeminal nerve. Why it is called mesencephalic? Trigeminal is supposed to be in the pons. It has got no business to go to the midbrain or the mesencephalon, but part of the trigeminal nucleus ascends upward. That is why it is called mesencephalic nucleus of the trigeminal nerve. Okay, there already 3 and 4 we have seen. This is the fourth nerve. This is the third nerve there, and then trigeminal ganglion also is formed there. And then you come down, and you have got the trigeminal ganglion here. This trigeminal ganglion is connected to the trigeminal nucleus, which is in this one. Okay, the blue one here you see that is the oculomotor nerve, and this is the trochlear nerve, the fourth nerve. 3, 4, and part of the 5. This is called the mesencephalic part of the trigeminal nerve. Whereas in the pons you have the major trigeminal nucleus, and the trigeminal ganglion is outside. This trigeminal nucleus has got 2 components. What are the 2 components of the trigeminal ganglion? Trigeminal nucleus? One is the sensory component and one is the motor component. The sensory component supplies ophthalmic, mandibular, maxillary, and mandibular divisions of the face. Whereas the motor component of the trigeminal is important for the mastication purpose. So facial nerve does not supply the masseters. That is why in facial paralysis, mastication is not affected. Ability to chew food is not affected. Only the lips and the other things are affected. So trigeminal nucleus has got 2 components. One component is the motor component, the other component is the sensory component. The motor component supplies the masseter and the masticating muscles, and the sensory component has got an ophthalmic division, a maxillary division, and a mandibular division. But the central nucleus is in the pons. Below that you have got the facial nerve there, and the facial nerve nucleus is there, and also you have got the vestibular nuclei there, which are elongated nuclei, the vestibular nuclei, and of course the cochlear nucleus also is there posterior to that, the cochlear nucleus, anterior cochlear nucleus and posterior cochlear nucleus. And this is the cochlear nerve, the red one below, above one is the vestibular nerve, and still above is the facial nerve. Okay. Facial nerve has got the 2 components again. One component is the taste component, the other component is the motor component. The taste component is the red color one, the motor component is the blue colored one. So both taste and this one together they go as the facial nerve, and these are very close to the vestibulocochlear nerve that is in the pons. Okay, now below that you see the medulla there, where glossopharyngeal and all other things are there. When we come to medulla, we will learn that. There is what is called the solitarius nucleus and tract. This is called the tractus solitarius. This is the motor component. Then there is a spinal nucleus of the trigeminal. This means what? The trigeminal nerve basically is having the nucleus in the pons with an extension to the midbrain, which we have called as mesencephalic nucleus. a projection downward into the spinal cord, which is called the spinal nucleus of the trigeminal. That is why lesions of the midbrain can affect fifth nerve, lesions of Pons can affect, lesions of medulla, lesions of the upper spinal cord, the fifth nerve can be affected because it's a very extensive nucleus from midbrain, Pons, medulla up to the spinal part of the trigeminal. Okay, so this is the structure of the Pons neuroanatomy. Now we go to the dorsal part. So dorsal part, as you see here, the nuclei are all in the dorsal part. This is the ventral part. This is mainly the corticospinal tract. The main nuclei of trigeminal, cochlear, facial, vestibular, all these are in the dorsal part of the Pons. Whereas ventral part is mainly the descending tracts and the pontine nuclei and the cerebellar fibers. So you can see here. This part is you can see, this is all the corticospinal tract, corticobulbar tract, whereas nuclei are much dorsal. Okay. So what is still dorsal to the Pons? This is Pons. What is dorsal to that? What is this one? That space, triangular space. Fourth ventricle. That's the floor of the fourth ventricle is formed by the Pons. The aqueduct of Sylvius is in the midbrain. Above that is the third ventricle. Between the two thalami is the third ventricle. It is connected to the aqueduct, which is a part of the midbrain, and below that is the fourth ventricle, which continues down into the cerebrospinal space of the spinal cord. So that's the fourth ventricle. The dorsum of the dorsal part of the Pons is the floor of the fourth ventricle. Okay, understood. Now we come to the dorsal or the tegmental part. So ventral part is called basilar part. Dorsal part is called the tegmental part. The tegment of the Pons continues from the tegmentum of the midbrain, and it contains cranial nerve nuclei. I have shown you now. The ascending sensory tracts are there. Reticular formation is there. Autonomic centers are there. It forms the upper part of the floor of the fourth ventricle. The lower part of the floor of the fourth ventricle is formed by the medulla. The dorsal part of the medulla is the lower part of the fourth ventricle floor. The upper part of the floor of the fourth ventricle is by the Pons. So what are the structures now in the dorsal part or tegmental part? All the ascending sensory tracts. So any lesion here produces sensory, plus also produces the cranial nerve. What are the cranial nerves? 5, 6, 7, 8. Okay, 5, 6, 7 cranial nerves with sensory involvement. If you see on the opposite side, it is mostly pontine, whereas dorsal region of the Pons. Okay. So what are the ascending tracts we have got? Ascending tracts we know is called lemnisci. These are called tracts in the spinal cord. When they go and in a compact way, they form one lemniscus, and it has got 4 components. Actually, the lemniscus, the medialmost part is called the medial lemniscus, which is what? Touch and vibration and proprioception from the cunate and the gracile nuclei which comes. These are the touch vibration, fine touch vibration and proprioception. That is the medial lemniscus. Next to that is the spinal lemniscus, which is the spinothalamic tract, which are crude touch, pain and temperature. That is the spinothalamic tract. Next to that is the lateral lemniscus. Lateral lemniscus, there should be one lemniscus called trigeminal lemniscus, but that is not here because trigeminal lemniscus is there from midbrain onward, because trigeminal nucleus starts from the Pons, and the trigeminal lemniscus starts happening only after the Pons. So trigeminal lemniscus is replaced by trigeminal nuclei. And lateral lemniscus is that part of the relay pathway to the auditory system, which projects into the inferior colliculus of the midbrain. These are the ascending tracts. Now, describe the ascending tracts in the dorsal and ventral part of the Pons. This is a short notes, let us say. So, just say what are the tracts in the ventral part and what are the tracts in the dorsal part. Tracts in the ventral part. Corticospinal tract, corticobulbar tract, pontine fibers of the cerebellum, pontine middle cerebellar peduncle, and then the crossing fibers of the cerebellar fibers. These are there. So and there are no cranial nerve nuclei here. We don't have 6, 7, 8, 9, 5. They are not there in the ventral part. Why I need to know? The ventral lesions do not produce cranial nerve palsy, but produce motor part, this one, and ataxia. Okay. Now, what are the tracts in the dorsal part? Ascending sensory tracts, in one word, is lemniscus. What are the components of lemniscus? Medial lemniscus, proprioception, fine touch, and joints. Lateral to that is spinothalamic lemniscus, which is called the spinal lemniscus. And next to that is the lateral lemniscus. Lateral lemniscus is the auditory. Actually, there should be trigeminal also in that. That will be missing here. Trigeminal is starting here. There is no trigeminal lemniscus. If you go above, you will have the trigeminal lemniscus. Because trigeminal is starting here. In midbrain, the lemniscus will contain 4. Medial, spinal, the trigeminal, and lateral. Here, trigeminal is missing. Okay. Now, these are the ascending tracts. In addition, what are there? There are nuclei are there. Fifth nerve nucleus is there. How many nuclei are there for fifth nerve? Motor nucleus is there. Sensory nucleus is there. One ascending component of the midbrain, mesencephalic nucleus. One descending component into the spinal cord, spinal nucleus of the fifth. So, these are all fifth nerve nuclei. As far as the eighth nerve is concerned, cochlear and vestibular. Cochlear, there is an anterior cochlear nucleus and a posterior cochlear nucleus. Together they become one nucleus. One nerve, that is cochlear nerve, and the vestibular nerve. And fifth nerve, the seventh nerve, has 2 components. One is the motor component, the other is the special sensory component or the taste component. Okay, so these are the various things. Now, what are the cranial nerve nuclei? We need to learn a little bit more. So trigeminal nerve, cranial nerve nucleus of the fifth nerve, chief sensory nucleus. It is also called the chief sensory nucleus of the face, and motor nucleus of the trigeminal nerve. Abducens nucleus is the sixth nerve nucleus. Why it is called abducens? Why it is called abducens? It produces abduction of the eye. Sixth nerve is an abductor of the eye. It takes the eye away from the center. It abducts the eye. That's why it's called abducens nerve. Why it is called trigeminal nerve? It has got 3 components. There's facial, ophthalmic, maxillary, and mandibular. Facial nucleus has got facial expression, nerve to stapedius, and also the corneal reflex efferent limb. The orbicularis oculi and orbicularis boris and the pacinator muscles, all these things are supplied by those things. Vestibulocochlear nucleus, both vestibular and cochlear nuclei are involved. Let us see a section of the pons as it appears. This is at the level of the upper pons, that is nearer to the midbrain. Supposing I take a cross section nearer to the midbrain, how does it look like? So these are the corticospinal tracts, the two ones, and then the decussation of the cerebellar peduncles are there. Then the medial lemniscus is there. Okay, and this upper part, medial lemniscus is there, and here it is the medial longitudinal fasciculus. Can you tell me what is medial longitudinal fasciculus? The one which connects both the eyes, all the 3 nerves, 3, 5, 4, 6 nerves of both the eyes are connected through one tract. That tract is from the medulla, from the pons to the midbrain. From the pons to the midbrain, there is a medial tract. One on the left side, one on the right side. These are interconnected. That is called the medial longitudinal fasciculus. I'll show you the diagram of that. Okay, then the superior cerebellar peduncle, and then the high above, you can say a little bit of the superior cerebellar peduncle also. Then you have got the mesencephalic nucleus of the fifth nerve. This is the part of the fifth nerve which is ascending towards the midbrain. That's why it's called the mesencephaly. This is the ventral part, and this is the dorsal part of the pons. Then decussation of superior peduncle and medial longitudinal fasciculus. Major important tracts are corticospinal tract, corticobulbar tract, and then the decussation of the superior cerebellar peduncles, medial lemniscus, and the medial longitudinal fissure in the center, and the mesencephalic nucleus of the fifth nerve. So let us go to the pons at the level of the mid pons. So let's say we have cut it at the level of the mid pons. Same corticospinal tracts will continue. The medial lemniscus is also there. Then the middle cerebellar peduncles are appearing, and then you have also the main sensory nucleus of the fifth nerve has come here. Main sensory nucleus and the motor nucleus of the fifth nerve are there in addition. So transospontine fibers are here. So we have understood the neuroanatomy of the pons. Now go to the more important part of the pons is the reticular part of the pons, reticular formation of the pons. There is what is called the PPRF, paramedian pontine reticular formation. What is the role of this reticular formation? Horizontal gauge center. Supposing whenever I am reading a book, what will happen? My eyes horizontally scan the book, this side to that side. Or you are watching a car show, car race is going. You are horizontally, you are going. For all that horizontal gaze, you require the PPRF, paramedian pontine reticular formation. Then you have got the locus coeruleus is there. Locus coeruleus is the noradrenergic nucleus. Okay, it is the sympathetic nucleus, important for arousal, attention, modulation of sleep-wake cycle. All this is sympathetic, and that locus coeruleus also is there in the pons. Pontine micturition center, which is called the Barrington's nucleus. So it coordinates the detrusor contraction and sphincter relaxation. Means what? Whenever the detrusor is contracting, the internal sphincter has to open first. External sphincter automatically will open once the urethra is having a few drops of urine. External sphincter opens. It is mainly the internal sphincter which is there controlled by the micturition center. So detrusor contraction and sphincter relaxation. Then also you have respiratory centers, pontine centers for modulating the respiratory rhythm generated by the medulla. The respiratory rate and rhythm is controlled by the pons, but the respiratory impulse is generated in the medulla. Whatever respiratory drive is generated in the medulla, we have got the chemoreceptors there, depending on the oxygen concentration and the carbon dioxide concentration. Either there will be hyper ventilation or hypoventilation, which is done by the medulla, and pons oversees that responses in the respiratory thing. Now you tell me, what are all the important functions of the reticular formation of the spine of the pons? PPRF, paramedian pontine reticular formation for horizontal gaze. Locus coeruleus for the noradrenergic drive. What does it do? Arousal, attention, modulation of sleep-wake cycle. Okay. Then you have got the micturition center and you have got the respiratory control center. These are the four important things in the reticular formation of the spinal cord. Now, look here at this diagram. You see the two eyes are there, right and left. Okay. Each eye is supplied by a lateral rectus, medial rectus, superior rectus. Of course, obliques are also there. Basically, superior, inferior, medial, and lateral. You see the cranial nerve nucleus 3. This is the blue-black one is the cranial nerve nucleus 3. Nucleus is here. This is the nerve. This is in the midbrain. This is CN3 nucleus. This is the oculomotor nerve. And the green, and you also got the trochlear nerve, the fourth nerve also is here, which is not in this picture. The fourth nerve also is here. And the sixth nerve is in the pons. And this is the abducens nucleus, abductor nucleus, abducens nucleus to the lateral rectus. Okay. And you have also got the sixth nerve nucleus here. The sixth nerve and the third nerve are the two important nerves. Trochlear also has got some function, rotatory function. And third nerve and the sixth nerve are coordinated by a tract. What is this tract called? Medial longitudinal fasciculus. That particular connections of the brain of the brainstem, which connect the third nerve to the sixth nerve, not only on one side but to both the sides. So this can control your leftward gaze, rightward gaze, and upper gaze and lower gaze. All those are controlled by these things. This is called the medial longitudinal fasciculus. Okay, there is the sixth nerve nucleus is here and paramedian pontine reticular formation. PPRP. Just now we have seen that paramedian pontine PPRP, it coordinates with this sixth nerve nucleus for the horizontal gaze. Okay, so third nerve, sixth nerve, medial longitudinal fasciculus, and paramedian reticular formation together control the movements of the eye, horizontal and vertical gaze. Suppose somebody has got a horizontal gaze palsy or a vertical gaze palsy, you have to suspect a lesion either in the PPRP or in the medial lemniscus, medial longitudinal fasciculus, or in the pons or the oculomotor nerve nuclei. For that reason, we are knowing this particular internal organization. So transections of the pons clearly show distinctions between the basis pontis and the tegmentum. Ventral part, densely packed white matter fibers, descending fibers, few pontine nuclei. Dorsal part, cranial nuclei, ascending sensory tracts, reticular formation. Fourth ventricle, much more dorsal. The important landmarks include the medial lemniscus, spinothalamic tract, and facial colliculus formed by the abducens nucleus and the fibers of the facial nerve looping around it. There is one projection on the pons that is called the facial colliculus. Facial colliculus is formed by the abducens nucleus coming out and the facial nerve winding around and the middle cerebellar peduncle later. So let us see the transection at the lower pons. We have seen upper pons and mid pons, and now we are seeing the lower pons. I am earlier midbrain, I have shown you two sections. One at the superior colliculus, one at the inferior colliculus. Today I am showing the pons in three sections. So what is the most ventral part? Corticospinal tract. And this is the medial lemniscus, there as usual. The medial lemniscus and the facial nucleus is there, and nucleus solitarius is there, and then middle cerebellar peduncle. There is no superior cerebellar peduncle is there. Dentate nucleus is there, and this is the projection called the facial colliculus, and this is the medial longitudinal fasciculus, which is the connection between the eye nerves of the recti muscles from pons level to the midbrain. Medial longitudinal fasciculus, the abscent nucleus, sixth nerve nucleus is there, and this one is the main sensory nucleus or the principal nucleus of the trigeminal nerve and superior salivary nucleus. The superior salivary nucleus and the facial nucleus are very close by. So this facial nucleus is responsible for salivation and taste sensation, and also the salivary gland supply, and also the muscles of the facial expression. All are supplied by this one. Okay. Now, so you see the projection from the cerebrum. You have got the corona. This is the corona radiata, the internal capsule, the descent, thalamus, the midbrain, and then the pons, and the medulla, finally into the spinal cord. Cervical, thoracic, and lumbosacral are oriented like cervical fibers, most lateral, and then the thoracic, and finally the cervical is the most medial, thoracic is the middle, and lumbosacral are the lateral. That's how they are disposed. You can see the color coded. Most lighter red color is the cervical, little more red color is the thoracic, and the dark red color is the lumbosacral. That means the fibers of the lower limbs are most medial, the fibers of the cervical are the most lateral in the disposition, and thoracic are in between. This is how the things come. We go to the physiology of the pons. Now we looked at I hope you understood the anatomy very clearly. Did you get it? What is the physiology? Sensory motor integration, corticopontocerebellar circuit. So the pons is the crucial relay in the corticopontocerebellar circuit, which underlies the coordination and fine-tuning of the movement. Cerebral cortex to corticopontine. That is cerebral cortex projecting to the corticopontine, and from there to the nuclei of the pons. Then the pontine nuclei to the cerebellum. So cortex tells the pontine nuclei. The first order neurons start in the cortex and end in the cranial nerve nuclei of 5, 6, 7, 8 nerves. Okay. And these nuclei further relate to the respective organs, to the face or to the vestibule or to the trigeminal part, the masseters and all that. Whereas the pontine nuclei connect to the cerebellar fibers. So corticopontine and then pontocerebellar fibers. Then middle cerebellar peduncle to the cerebellar cortex. These three loops, one is the cerebral cortex to corticopontine, next one is the pontine nuclei to transverse pontocerebellar, and the middle cerebellar peduncle to the cerebellar cortex. These three loops, motor commands from the cortex, are compared with the sensory feedback. Suppose there is a motor command is there, and the sensory feedback corrects how much amount of movement is required based on the proprioceptive senses, allowing the correction of errors and motor learning. Lesions in the circuit produce limb and gait ataxia, dysmetria, and intention tremor. So involvement of this region of the pons, which produce limb ataxia, gait ataxia, dysmetria. What is dysmetria? Finger nose is a manifestation, unable to measure the distance. Suppose he is doing, he will not know where the tip of the nose is there. Because of dysmetria, he will either past pointing or undershooting will occur. Dysmetria and intention tremor. Lesions of this will produce gait ataxia, dysmetria, intention tremor, in addition to the corticospinal lesion, which produces a hemiparesis on the hemiplegia on the opposite side. Okay, that is about the sensory motor integration. Then come to the eye movement and physiology. So it's very important. Pons is the one, mainly it is controlling the horizontal gaze, and horizontal gaze is coordinated by a network of centers in the pons. One is the PPRF, which is the paramedian pontine reticular formation, acts on the horizontal gaze. Paramedian reticular formation projects to the ipsilateral abducent nucleus. Abducent nucleus gives rise lower motor neurons to the ipsilateral lateral rectus. Interneurons that cross the midline and descend in the middle longitudinal fasciculus to the contralateral oculomotor nucleus for activation of the medial rectus. Did you understand that? Whatever is written there. So let's look at here. Look at me. Now, left side is there. Left side there is the sixth nerve nucleus is there. If the motor moment comes, the order comes, you have to move the right eye to this side and the left eye to medially you have to move. So first of all, the order comes from the cerebral cortex, and in the epsilon nucleus is stimulated, the second order neuron, lower motor neuron goes and pulls the lateral eye. Simultaneously, this information is crossing to the other side and ascending through the middle longitudinal fasciculus to the third nerve nucleus on the left side. Third nerve pulls the eye medially. So this eye, left eye is pulled medially, right eye is pulled laterally. You have got a horizontal. What a beautiful coordination. So this is happening because of what are all the things? The abducent nucleus, the medial longitudinal fasciculus, and the third nucleus in the midbrain, together commanded by the cerebral cortical impulses, is producing the horizontal gaze. Okay. Now, a single command from the frontal eye field results in a conjugate gaze movement. What is frontal eye field? Here, this eye field is there, no? This part is called the frontal eye field. This is called the temporal eye field. This is called the nasal eye field. Any moment here, little moment, you turn your head as well as neck. Okay. So thus a single command from the frontal eye field results in the conjugate gaze movement. Lesions at different levels in this circuit can produce characteristic conjugate gaze policy. Internuclear ophthalmoplegia. So you may be asked, what is internuclear ophthalmoplegia? What is internuclear ophthalmoplegia? Yes. Contralateral nystagmus and 1.5 syndrome. It is also called the 1.5. I don't know whether you are aware of that. Facial expression and corneal reflex. This is also controlled by the Pons, because the facial nerve oculomotor nucleus, the orbicularis oculi nucleus is the efferent of the corneal reflex. Corneal reflex, I have told you, the afferent limb of the corneal reflex is trigeminal nerve. That is the V1, that is the ophthalmic part, branch 1, that is the afferent limb. Interneurons are there in the pons, and they connect to both the facial nuclei. That is why if I stimulate the cornea on the right side, both eyes blink, because both the facial nuclei are involved. That's why the efferent is the efferent limb. That is the motor limb is the facial nuclei. The sensory is the C1, V1, the first branch, ophthalmic branch. Interneurons connect to both the facial nuclei and produce a orbicularis oculi contraction, causing bilateral blinking. Lesions involving the pons can therefore produce loss of corneal reflex, facial asymmetry, and hyperacusis because of the stapedius particular muscle is not properly working. So when you, supposing, I give you an example. Let us say I tested the corneal reflex. Corneal reflex is not elicited. Means where could be the lesion? In the brainstem. Corneal reflex not elicited by afferent, not working. That means the fifth nerve nucleus is affected. Suppose fifth nerve is all right, but there is no blinking. Seventh nerve is affected. So, efferent limb is the seventh nerve, afferent limb is the trigeminal nerve. Then you also have the auditory part. Okay? Auditory and vestibular physiology. So many things are integrated in the bridge, that is the pons. The cochlear nuclei in the pons receive input from the organ of corti. Cochlear nucleus in the pons, they receive input from organ of corti. Their projections via the lateral hemisphere participate in binaural hearing and localization of the sound. So what happens? When you are hearing a particular sound, you are able to locate whether it is coming from the right side or left side. That is possible because of the pontine connection. Vestibular nuclei integrate the information from semicircular canals and the otolith organs and in the utricle and the saccule, and with the oculomotor nuclei, the cerebellum, and the spinal cord to maintain a balance and coordinate oculovestibular reflex. So, oculovestibular reflex is again coordinated through the pons. And you have got autonomic functions. Pontine respiratory centers modulate the rhythm generated by the medulla, influencing the inspiratory and the expiratory switching and the respiratory rate. So, modulation of the respiratory activity. Then, pontine micturition center coordinates the bladder contraction with the sphincter relaxation. Lesion can lead to urinary retention initially, followed by overflow incontinence. Through the connections with the medullary cardiovascular centers and higher autonomic centers, Pons participates in the regulation of the blood pressure and the heart rate, respiratory control and micturition control, and then blood pressure and heart rate control. More importantly, the arousal and attention and sleep-wake regulation. The locus ceruleus, which is the noradrenergic component of the pons, in the dorsal pons, is the major noradrenergic nucleus. Locus ceruleus promotes wakefulness and vigilance. If locus ceruleus is under stimulation, person is wakeful and vigilant. If the locus coeruleus activity is suppressed, then the person will get into sleep. Modulates the attention, modulates the learning, modulates the memory. Shows altered activity across sleep stages, particularly rapid eye movement sleep, and degeneration or dysfunction of the locus coeruleus neurons has been implicated in the neurodegenerative diseases and sleep disorders and mood disorders. Okay. Now, come to the blood supply of the pons. Because this is very important to know the blood supply. Arterial supply of the pons and vascular syndromes. Right on the basilar groove, there is a basilar artery. That basilar artery gives branches there, and the pons is supplied mainly by the branches of the basilar artery and contribution from the anterior inferior cerebellar artery, AICA, and the superior cerebellar artery. Let us see the diagram of that. Here, I put it immediately there. Arousal, this is the blood supply. Yeah. You see, the red color one is the basilar arteries in the basilar groove, and these are the two middle cerebral arteries there, and this is the two posterior cerebral arteries. This circle of Willis is formed there around the optic chiasma there, and this is producing many branches. These are called the branches, the small branches of basilar artery. There is one large branch also is there. There is anterior inferior cerebellar artery. This is the anterior inferior cerebellar artery. So there is a syndrome. What is that syndrome here? Posterior inferior cerebellar artery thrombosis. Wallenberg syndrome. Wallenberg syndrome is pons and cerebellum together are affected along with the motor. This one. So this is the spinal artery, anterior spinal artery from the two vertebral arteries. The green ones are the two vertebral arteries. Two vertebral arteries join to form the basilar artery. Basilar artery divides into posterior cerebral arteries and the circular Willis. These are the middle cerebral arteries there. And then the main branches of the basal branches of the basilar artery and larger branches supply onto the side and then go there. And you have got also the posterior inferior cerebellar artery. All these are the arteries which supply. Let us look at the pons. This already, as per the blood supply, let us look at which part is supplied by a part. So you can see the light green color is the basilar artery. AICA is the relatively darker bluish green color. So that is the AICA. So the mainly two arteries are supplying, the basilar artery and anterior inferior cerebellar artery. So basilar artery syndromes produce this part, which is the corticospinal tract. Anterior inferior cerebellar artery, the dorsal part of the pons is affected, so much so sensory and cranial and nuclear are affected. Very easy. Basilar syndromes will produce motor defects. AICA syndromes produce sensory defects and cranial nerve defects. You can easily find out from this diagram which particular area. Classical pontine vascular syndromes. What is the type? We'll go through these things one by one. Millard-Gubler syndrome. You will be asked about these things, no doubt about that. What is Millard-Gubler syndrome? It is a ventral pontine lesion involving the corticospinal tract and the facial nerve fibers. Okay, what will happen? Ipsilateral lower motor neuron paralysis of the face and contralateral hemiparesis. What is Millard-Gubler? Ventral pontine vascular syndrome. Corticospinal tracts are involved. Ipsilateral lower motor neuron facial palsy, contralateral hemiparesis. Then Fowler's syndrome. What is Fowler's syndrome? Lesions involving the PPRF. PPRF is para-pontine reticular formation. When the para-pontine reticular formation is affected, abducens nucleus, facial nerve fibers, plus corticospinal tract, all are affected. Horizontal gaze palsy towards the side of lesion. That means if there is a lesion on the right side, patient will not be able to move the eyes to the right side. Okay, horizontal gaze palsy towards the right side, to the side of lesion, ipsilateral facial paralysis, contralateral hemiparesis. Now, what is the difference between this and the Millard-Gabler? Millard-Gabler syndrome, there is no horizontal gaze palsy. Here, there is ipsilateral facial paralysis, contralateral hemiparesis is common to both. If you have horizontal gaze palsy, it immediately puts the lesion around the PPRF. And around the PPRF is the abduction nucleus and the facial nucleus. So, more central lesion, more medial lesion. That is why it is Fowley's syndrome. Then, anterior inferior cerebral artery syndrome. AICA syndrome, infarct of the anterior inferior cerebral artery territory, ipsilateral facial palsy, ataxia from cerebellar and peduncular involvement, vertigo, tinnitus, and hearing loss because of the vestibular involvement. So, what is AICA syndrome? Ipsilateral facial paralysis. There is no motor involvement. Why there is no motor involvement? You see here, what is this one? AICA is not supplying the corticospinal tract. Corticospinal tract is light green color there. The light green color is the corticospinal. The dark green is the AICA supply. So AICA is not supplying the corticospinal tract. So much so there is no motor weakness, but ipsilateral facial paralysis, ataxia of the from cerebellar and peduncular involvement, vertigo and tinnitus, and hearing loss from the vestibulocochlear involvement. Then you have got the Lockhart syndrome. What is Lockhart syndrome? Usually due to bilateral ventral pontine infarction, also called the basilar artery thrombus. The main basilar artery is occluded, the branches to both sides are affected, so much so there is a bilateral ventral pontine lesion. What will happen? Ventrally, what is there? Corticospinal tracts are there. So quadriplegia will be there, anarthria, inability to speak due to interruption of the corticospinal and corticobulbar fibers, and preserved consciousness, ventral eye movements as reticular formation, midbrain vertical gaze centers are spared. Vertical eye movements are spared, and then vertical gaze is spared, and then reticular formation is spared because the ventral lesion, consciousness. So if a patient is not having consciousness disturbance, had got quadriplegia on both the sides, associated speech disturbance, anarthria, corticobulbar tracts are affected, he may have a little bit of ataxia also, and he has got consciousness is preserved, gaze pulses are not there. This is called the locked-in syndrome. Okay? Then, case-based approach, localization. Case 1, horizontal gaze palsy with lower motor neuron facial weakness. Tell me where it is. Horizontal gaze palsy with lower motor neuron facial weakness. Conjugate gaze is affected. Ipsilateral element palsy, it is a Fowley's syndrome. Okay. Dorsomedial pons involves abducent nucleus and facial nerve, likely vascular territory, paramedian branch of the basilar artery. Paramedian branch of the basilar artery. Then, quadriplegia with preserved consciousness and vertical gaze. This is locked-in syndrome, isn't it? That means patient is awake, communicates with vertical eye movement. Vertical eye movement is there, or blinking, but has complete limb paralysis and anarthria on both the sides. Bilateral ventral pontine lesion means basilar artery thrombosis. This is called the basilar artery thrombosis. Then you have dissociated sensory loss, ipsilateral face, contralateral body. Sensory is involved, must be dorsal because ventral is the spinal thalamic tract, corticospinal tract. Loss of pain and temperature on the ipsilateral face with contralateral loss of the same sensations on the opposite side. Location, lateral pontine lesions involving the spinal nucleus and tract of trigeminal nerve plus the spinothalamic tract. Okay, spinal lemniscus and then the medial lemniscus are affected. Associated features may be accompanied by ataxia, vertigo, facial weakness, depending on the territory. AICA. We know AIC is the one which supplies the dorsal part of the pons. Okay. Ventral part is supplied by the basilar artery, where you have motor symptoms. Dorsal part is supplied by the AICA artery, where you have got sensory symptoms. Ipsilateral face, contralateral body, sensory only unaffected, motor not affected, AICA syndrome. Okay. medial superior pontine syndromes occur secondary to the compressing tumors on the upper and medial portion of the pons or a stroke affecting the paramedian branches. Clinical findings are what will happen? Medial superior pontine syndrome. Ipsilateral lesion, ataxia due to superior or middle cerebellar peduncle, internuclear ophthalmoplegia will be there, contralateral paralysis of face, arm, and leg. If I have ipsilateral ataxia and contralateral this one, spinal, corticospinal effect, it is a superior pontine syndrome. Then you have got lateral superior pontine syndrome or syndrome of the superior cerebellar artery. This is not AICA, but the superior cerebellar artery. Ipsilateral ataxia, limbs and gait, dizziness, nausea, vomiting, horizontal nystagmus due to vestibular dysfunction, paresis of the conjugate gaze, pontral contralateral Horner syndrome may be there due to descending sympathetic tract lesion. And contralaterally, this person will have impairment of thermal sensations on the face and limbs because of the fifth nerve. Touch, vibration, and position sense may also be impaired predominantly in the leg. There is a tendency to incongruity between pain and touch due to lesion in the lateral portion of the medial lemniscus. What we are saying here is, if the medial lemniscus is affected, medial lemniscus effect produces pain and fine touch and then the vibration, other things on one side. Whereas spinothalamic effect produces the pain and temperature. That is why it is a dissociated sensory. Syndrome of superior cerebellar artery, dissociated sensory loss can be seen. Medial mid-pontine syndrome due to paramedian branch of the mid-basilar artery. This is a stroke, apoplexy, ipsilaterally ataxia due to pontine lesion, contralaterally face, arm, leg paralysis, variable loss of touch and proprioception. This is a mid-pontine syndrome. Then you have got lateral mid-pontine syndrome, short circumflex artery. That is, there is an artery which winds around the pons and supplies the lateral part of the pons. And it affects, produces paralysis of the muscles of mastication, resulting in the lesion due to the motor fibers. And trigeminal nerve, diminished sensation on the face. Supposing you have diminished sensation of one half of the face and also the masseter muscle and the mastication muscles are affected, then it is a lateral mid-pontine syndrome. Medial inferior pontine syndrome, secondary to the occlusion of the paramedian branch of the basilar artery. Ipsilaterally paralysis of the conjugate gaze and ataxia, nystagmus, contralaterally face, arm, and leg paralysis. So this completes almost all the pontine syndromes. You could have a essay question on give me a list of all the pontine syndromes, 9 types of scenarios I have described. I am going to share this PDF with you so that you can see, correlate with the anatomy also. Then we have got one more thing called the cerebellopontine angle. This is very important for you to know. Cerebellopontine angle I have shown you in the diagram. Clinically important, it is often the place of intracranial growths, cerebellopontine angle tumor, CP angle tumor, which can lead to impairment of the nearby structure. It is not intracerebral or within this one, but there is an extraneous pressure due to what is the commonest thing is a schwannoma. Schwannoma of the vestibular nerve, which can produce the schwannoma. They are generally growing, frequently very slowly growing tumors. Ipsilateral hearing loss because of the involvement of the vestibulocochlear nucleus, vestibular schwannomas, 80% of the cases. And it can range, and sometimes meningiomas also may be there. Then ipsilateral hearing loss and tinnitus, disequilibrium and more rarely vertigo, nystagmus due to compression of the cerebellar flocule. Untreated, large tumors will lead to compression of the additional structures with facial paralysis may be there, reduced corneal reflex, trigeminal palsy, ipsilateral cerebellar signs, surgical resection guarantees a good outcome in most cases because these are benign tumors with the risk of complications increasing with the size of tumors. Now, describe CP angle features. What are CP angle tumors? Tell me. Mostly it is a schwannoma or a meningioma It is only, it is benign and surgical outcomes are good. It produces unilateral, ipsilateral hearing loss. Vertigo will be there. Tinnitus will be there. Okay? Tinnitus, vertigo, and then hearing loss ipsilateral. Disequilibrium, rarely vertigo. Nystagmus due to the compression of the follicle. If the tumor is quite big, it can compress the facial paralysis. And then every patient of facial paralysis, you must consider CP angle. Don't dub it as, Bell's palsy. All facial paralysis are not Bell's palsy. If there are associated features like nystagmus, hearing loss, tinnitus, vertigo, tinnitus may be there in Bell's palsy also. Hearing loss, disequilibrium, vertigo, nystagmus are there. Facial paralysis needs to be investigated. Check for the corneal reflex. Why the corneal reflex is absent? Due to the involvement of the motor component of the seventh nerve, that is the orbicular circuli, or the sensory afferent of the fifth nerve. Trigeminal palsy also may be there because trigeminal also is close by. Ipsilateral cerebellar signs also in the advanced stages. Now there are two more sections I have put here. High yield summary for PG examination and OSK. This is for you. From 9 onwards, for a quick recap, you can go through all these points. 9 and the appendix, some MCQ questions also I have appended. You can try to answer these MCQ questions by yourself, and also the OSCE stations, horizontal gaze palsy, facial plus limb weakness, absent corneal reflex, locked-in syndrome, dissociated sensory loss. So whatever we have discussed, I have put them. And for a quick revision also, I have added some sections. So from 9 onwards, you go through the document and strengthen your understanding. And for recap, this document I'm going to share. Maybe we'll stop here. This is about the Pons, and maybe we will come back to medulla in the next week. Okay. So we'll stop here.